Looks good. Well, it's great to see all the amazing faces here with us today. Welcome, welcome, welcome. Hi, everyone. Good morning. I'm Fran Ayala Somiajala, the president of Reach Healthcare and the chair of the Match Coalition. I'm joined by the co-chair, David Gray, who'll be with us just momentarily from HIMSS. We're about to get started on what is going to be a fantastic innovation showcase. We heard from you that one of the things that you wanted to hear more of during this meeting is innovations, opportunity to hear from those who are on the front lines and the cutting edge of new approaches to improving overall health and well-being for those on the maternity journey. So without further ado, I'm just going to just very quickly allow, as we do every month, anyone who has an announcement they'd like to make in relation to perhaps some events that are coming up, major conferences, or whether it's local, regional, or national. We'd love to hear from you. Anyone have any announcements to make? Dr. Bachman, always something exciting happening in New Jersey. Anything you want to share with us today?
Well, we've had a lot. You have to get involved with New Jersey Reentry Commission because they do so much for veterans and individuals who are reentering. So we just had a very nice get together with them. And everybody's welcome to the New Jersey Obstetrics and Gynecology meeting on November 8th. Just email me and I'll give you the information. We're going to be meeting with legislators on women's health.
Fantastic. Well, thank you so much. Thank you for that update. Anyone else like to share before we get started? All right, well, we have an amazing lineup, and looks like David is just joining us now. I'll get things kicked off for him in terms of legislative update, which is, of course, the next thing that's on our agenda. As everyone knows, we are in the midst of presidential campaigning, and a lot of local and state officials are out there campaigning as well for what makes for a very if I may use the word entertaining weeks. But other than that, I don't know, and I'm going to lead it over to David. I'm not aware that there are any major dialogues, unfortunately, around maternal health, although we would love to see that in particular. Again, reproductive health and maternal health are two different topics. They share a thread, obviously, but they are different topics, and we're focused on maternal health. But that is not my area of expertise. That is why we've got David. So, David, welcome this morning. Any updates, legislative updates you'd like to share for us?
No, not really. I think the one thing that we're continuing to monitor and talk about as Congress is out campaigning, as you mentioned. There will be, when they get back, they have one thing that they need to do, which is extend federal funding beyond December 20th, hopefully pass a fiscal year 2025 appropriations package that includes some increases in funding or staves off cuts to funding, especially in the healthcare and public health spaces. The other thing that they would really need to do is there are a number of healthcare provisions and policies that are expiring, such as all the Medicare telehealth flexibilities. And we expect there to be a healthcare package of some size. We are continuing to talk about maternal health legislation. There are a number of bipartisan bills that have seen movements, such as the Preventing Maternal Deaths Reauthorization Act, which would reauthorize and provide funding for maternal mortality review committees. This is a bill that Dr. Michael Burgess has championed. He is retiring. It would be great to see this passed and signed into law. And of course, all of the other, momnibus bills that we're supporting and other data and technology and maternal health legislation, we're continuing to raise awareness and education on. If there is an opportunity to get anything attached to packages, we are going to do that. But these are conversations we're having now, and when they come back after the elections in November, we'll see what type of appetite there is or room for maternal health legislation to move. But other than that, no real updates other than we're continuing to have conversations and express our support.
Well, that's fantastic. I think that's where it always begins, right? We have to keep the ball moving along and maintain our momentum. So we appreciate your activeness and keeping your ear to the ground on everything that's happening and identifying opportunities for us to make sure that our message around the clinically appropriate applications of technology for maternal health are integrated where they most appropriately and effectively can be attached. So thank you for that. Well, everybody, we've gone through the legislative update. We've talked about some happenings within your neck of the woods. Now we're going to turn our attention to our innovation showcase. And for this, Kelsey is our most recent join, who is our Match Coalition coordinator, and I'm excited to introduce her. And Kelsey is going to give us the lineup of our innovation showcase presenters today. Kelsey, I'm going to put it on the screen for you if I can find where the button is to share my screen. I'll put the agenda up so everybody can see it. Everyone should have received a copy of this. Hopefully you can see that well. All right. And Kelsey, are you on mute or are you good?
I think I am on, and thank you, David. I appreciate that. So up first today, we have Amy Romano. She's the founder and CEO of Primary Maternity Care. She's going to be speaking on their Step Up Together program, which is maternal health coverage. I'm really looking forward to that one. After that, we have Dr. Sunny Ranawat. He's the Chief Executive Officer for Fetal Life, and he will be talking on smart devices for healthier pregnancies. And then finally, Neil Friedman and Ed Barron, Dr. Ed Barron from Circle Health by Body Metrics and GT Cardio will be giving a presentation on wearables and remote patient monitoring.
Okay. Thank you, Kelsey. Now we do have a little bit of housekeeping notes here. I know everyone's going to have a lot of questions, but we're going to hold our Q&A to the end so that we can maximize the amount of time and make sure that all of our presenters have the opportunity to present their solutions. So if you can't hold your question, pop it into the chat window or write it down so that you can come back to it when we come to the Q&A portion of today. Each of the presenters is going to we're giving them a generous 8 minutes to present their presentation, but certainly during the Q&A session, they'll have more time to do so. So without further ado, we're going to go ahead and I'm going to put the spotlight on to Amy.
Thank you, Fran and Kelsey and David. I'm going to pull up some slides here. I thought I had 6, so I'm burning part of my extra 2 minutes here. My name's Amy Romano. I'm really grateful to be here. I wanted to start with this photo, which is a picture of me in April 2020 with one of my colleagues on the left there, Jen Johnson. I was fresh off my second not successful startup effort to scale up midwife-led models of care. And I got a call asking if I could be part of a team to do what nobody had done in New York City in decades prior, which was to open up a safe out-of-hospital birth setting. This was the first wave of the pandemic. New York City was ground zero of it, and people were flocking out of the hospitals and looking for any alternative to a hospital birth when things were just out of control in the hospitals. And so we brought together a team of people that had never met each other, who had flown in from other states, were working on their out-of-state licenses. You're looking at us prepare a birth setting in a hostel in Midtown that ran and operated as an out-of-hospital birth center in collaboration with Mount Sinai Hospital for close to a year while things settled down. And then when the kind of regulatory framings came back in, this place closed and it's a hostel again. The pandemic was just the beginning. And in fact, it was not the beginning. It was an accelerant of a trend and a set of trends that have been going on for a number of years and that are becoming emergency in nature. So we did see a massive increase, some of which has been sustained in the interest in out-of-hospital birth, both home births and freestanding birth centers. That started with the pandemic, but more troublingly, we have seen closures of a lot of obstetric facilities and entire swaths of the country that don't have access now. So the March of Dimes tracks what are called maternity deserts, and we've seen those grow, and now more than a third of counties around the country with a lot of sort of geographic intensity in certain areas have no birthing facility and no obstetrician or practicing nurse midwife at all. And so if there's one thing that I knew from my experience opening a pandemic birth center, experience running a number of birth centers and midwifery practices prior to that, working in efforts around quality to improve out-of-hospital birth safety, it's this: seamless and safe transfers save lives. And we have reached a point in this country where we've gone from out-of-hospital birth being kind of like a boutique luxury thing that only sort of people like me would go and try to do, to something that we're all living with, because we simply have entire parts of this country where people are going to give birth in their communities, whether they like it or not. And more people are going to be changing levels and locations of care during their care, including during emergencies. And so we need to have plans, and we need to have collaboration. And so that is why I started primary maternity care in that early pandemic time so that I could do that pandemic birth center project. And we started Step Up Together, our sort of internally incubated program, soon after, really to start testing this and seeing how we could scale what we know are good tools and models to do this. So I wanted to share some pictures from some of what we've been doing with this program just over the last year or two. These are some photos from earlier this year in a rural birth center in upstate New York, where we had a team that had never met each other before, but who relied on each other for continuity of care for their pediatric neonatal patients, these babies that are born in this birth center that is in a maternity desert. It's the only maternity facility in that desert. And so this neonatal transport team that also goes and picks up babies in outlying hospitals and other community-based locations had an opportunity to come and train together using our tools and program with the midwives and nurses that operate this birth center. We also just recently had one of our programs in Detroit, so in a totally different setting, urban setting, a birth center being opened. Actually, they just did their ribbon cutting last week. You can see them practicing for emergencies, doing a simulated clinical emergency without even walls up on the left-hand side. So they are practicing all of what's involved in moving a patient, in this case, if there is a hemorrhage. So you can see the hemorrhage being called, and then the patient, the same team arriving in the hospital and now interacting with the hospital-based team there for continuity of care and management of that obstetric emergency. So what we actually do is it's a pretty low-tech intervention for a tech innovation showcase, but it is technology. We've built a website and that's interactive to produce tools that are appropriate for whatever the setting is and whatever the learning objectives are for the people practicing emergency preparedness. We create opportunities for community so that different practices, a rural birth center in upstate New York and an urban birth center about to open in Detroit, can learn lessons from one another, and the hospitals and EMS teams that they work with can also learn from one another. So we create spaces and communities for that community to happen. And then we provide coaching from myself and my team members who have done this many different ways now and have a lot of lessons to share. All of this is at stepuptogethernow.com. And we have made incredible progress. This program, we started piloting different versions of it in 2021. And since then, we've had 37 live drill events. So the main thing that we do is we practice emergencies that begin in a community-based setting, move by emergency transport, and end in a hospital. So 37 different practices or combinations of groups have done that in their locations across 17 states, involving over 323 participants. And we just kicked off another round. So these numbers are about to explode because we have 41 states that just signed up to do this in the next round. All of this has been made possible by funding from United Healthcare, which has really come behind this urgency and seen the importance of this program and given us our major funding this year, along with initial funding from the Skyline Foundation. We've worked with AIM and ACOG to around spreading this, and they've included it in their recent toolkit that came out around transfers. And we've worked with other partners and really see a lot of interest in this program growing, not just for out-of-hospital birth, but for all kinds of perinatal emergencies that can present in those settings. So I'll wrap it up in just a minute here to say what we are looking for is more opportunities to scale, more funding to bring this to more hospitals and facilities and community-based practices next year. And we are currently recruiting more practices into our current cycle that just kicked off last week. And all of this, again, is at stepuptogethernow.com, and our email address is there if you want to get in touch. Just a sweet little picture of our baby on the move after they've been stabilized in our birth center. And I really thank you for the opportunity to talk about this program and to answer whatever questions come later. 11:18 on the dot. Thank you.
Wonderful. Thank you, Amy, so much, and very much impressive. As perhaps some may not know, when we talk about the major causes of mortality, morbidity and mortality that are preventable, there are 4 delays. And one of those 4 delays is just what Amy has spoken with us about today. So very exciting to see the approaches that you're taking to addressing that particular challenge that we're having. Thank you so much. And now we're going to turn our attention to our next presenter, Dr. Sunny Dornawat, who is the Chief Executive Officer of Fetal Life.
No, unfortunately, I just got off the phone with Dr. Sunny. He is stuck in Dubai, so he will not be able to make it. He is currently trying to forward the information to have someone else attend. If he makes it in time, I'll get him in here.
Thank you, Kelsey.
And he
why don't you go ahead
apologizes.
That happens. That's why we're, this is what happens when you're alive. So let's go ahead and move on to our next innovators. Kelsey, if you'd like to introduce them.
Yes, I would. So up next is Neil Friedman with Circle Health and Body Metrics, and Dr. Ed Barron from X Cardio.
Okay. Thank you very, very much, Fran and Kelsey, for inviting us to this webinar. We believe that we have an extremely innovative device that will help change maternal health care in the area of preeclampsia. Both Ehud and I like to talk, so we know we have minimal time, so I'm going to actually turn it over to Ehud, who I've collaborated on and developed this new product that we're going to bring to you. I'm having a degree of trouble here. Go ahead, Ehud.
Okay, so first I have to apologize. I'm not from the field of maternal health, not a gynecologist, I'm a cardiologist. So forgive me for not saying things that I'll tell only about the cardiovascular system and focus on one major problem, which is, of course, preeclampsia. And as you know, this is a problem that is growing now very fast, especially in third world countries like Africa and so on, but also in the US. And the main problem is that we can detect the preeclampsia by measuring blood pressure. But this is many times too late because it will be on the 20th week or even later. And when the damage is already done. So our focus is how to detect it in earlier stage in a way that is not obtrusive to the pregnant women and something that everyone can do at home. And the way that we do it is what you can see on me. It's a watch and a ring, and this is the result, which is a graph, which shows the fluctuation in blood pressure over the night. now you can say why we need to do this, because you know that normally we would encourage women to measure their blood pressure every day or as often as they can. And many don't do it. And one thing that I want to show is that measuring blood pressure only once a day is not enough. And what you can see in the first slide is something very interesting. This is the blood pressure minute by minute, or actually second by second, over 8 hours of sleep. And when you ask people, they normally say it should be flat, but actually you see there is a lot of spikes and blood pressure going up and down. And these spikes can be very high, can be up to 100 millimeter mercury in one spike. And the clinical significance of this is that this is the first sign that something is wrong. Long before we can see the increase in blood pressure, we can see these spikes. So if we detect these spikes, then we can treat them in an early stage and we can prevent the preeclampsia. If we wait, then it might become too late. And if you go to the last slide, I prepared only 3 slides. This is a little bit explanation of why this is so important, the spikes. Because people can say, okay, so the blood pressure goes up, goes down, nothing wrong. But this is a sign of something that maybe you remember from medical school, maybe not, because it's not emphasized enough. There is an endothelial layer in all the blood vessels. And this endothelial layer plays actually a very important role in preeclampsia and hypertension in general. Actually, in all cardiovascular disease, because this is like the first line of defense. And when this fails, then start the spikes. And when the spike starts, they start to make all the other problems. For example, they will create the atherosclerosis. They will make the resistance of the blood vessels higher, so create hypertension. They create problems with aggregation of platelets that can cause blood clot and many other things. So if we can detect it in early stage, this can be a major thing. And the last thing that I will say is that preeclampsia is not only a problem during pregnancy. It turns out that it raises the risk of cardiovascular disease in 30% or even more in women that had it. So it's not only an immediate problem, it's also for the long term. That's about it.
Okay.
This was my presentation. So any question, I will be happy to answer.
Thank you, Dr. Barron. And then we'll pass it over to Neil.
I have nothing more to say, really. Ehud has really told you about our technology. As he mentioned, we use 2 FDA cleared devices. One is what is known as the Circle Pro Ring, and one is one of 2 blood pressure watches, which Ehud showed you, that also has a bladder in it. And if we have the opportunity later in our questions and answers, we'll explain to you how we can detect those spikes that happen beat to beat, because the Circle Ring has the ability to monitor blood oxygen at 1/100 hertz, or 100 measurements per second.
Okay, well, fantastic, and we appreciate your presentation. Certainly, we do recognize that cardiovascular related complications are the number one cause of morbidity and mortality amongst those who are pregnant. And I love the fact that you have pointed out that that continued risk, in fact, does continue during the postpartum period. So really excited to be able to dive deeper into your solution as well.
Thank you.
All right. Thank you both so much. I'm going to just adjust the screen here and get the, there we go, and bring everybody back. So why don't we open it up and invite folks to come back onto their cameras. Kelsey, just really quickly to make sure, I know we've got, you had mentioned there was a possibility of someone coming in from Fetal Life to speak. Just want to make sure that I haven't overlooked that in case someone has joined us.
No, I just got off the phone with Rishi, and they say it's just best to join in November if they can.
Sounds great. Well, we'll see them then. Well, everyone, thank you so much. We've got quite a bit of time available for dialogue, and that's what it does need to be about. And I'd like to just kick us off and get us warmed up. Amy, why don't we begin with your solution that your team has created? Sometimes it's very challenging to try to coordinate these types of very necessary solutions and approaches. Can you share with us a little bit what it was like in the beginning when you were attempting to orchestrate this and really set the tone and the priority of putting together the program that you've created?
Sure, Fran. You mentioned after my talk the 4 delays, and I need to hear from you what they are. I learned them way back when I was doing global health as the 3 delays, but I'd love to. I think is the 4th one the patient?
Well, the 4 are transportation or delays in transportation.
Yep.
And that can be on the part of the facilities themselves transferring to units, or the patient not having access to transportation.
Okay.
The second one is seeking care. So oftentimes this happens because, individuals may not know the signs and symptoms, or a lack of trust between the patient and the provider team. That rapport not being there. The third one being delays in diagnosis as well as misdiagnosis. And the fourth being delays in treatment and appropriate treatment. So those are my 4, but I'd love to know your 3.
Well, I bundle up the delays in seeking the higher level care, and that can arise from the delayed diagnosis. The clinician or the patient both have roles in that. So I kind of like yours, but so we talk about the 3 delays of sort of realizing there's a problem, getting to help, and then receiving help when you get there. And I think that when people have looked at out-of-hospital birth or midwives that do home birth or have birth centers, there's often just an assumption that all of the delays are in that first bucket, and it's all about, delaying the decision to move the patient. And, those obviously do exist. And as you mentioned, there's cultural factors, and there's ways that midwives and patients that have chosen out-of-hospital birth are treated historically when they do show up for necessary care. And so that contributes to those first delays. But it is really important, and I think there's finally been some realization from the kind of quality improvement community that is so focused on hospital-based quality improvement, is that those other delays are there too. And there's many, many cases when you look at, when you do root cause analysis of cases, you do see that delays can creep in, and that those are contributing to some of the poor outcomes. So I think, to answer your question about what we did early on, is we have since the beginning framed it as a problem of the whole system, but we focused on the midwives and who are just closest to these models of care. And so in our initial versions of this program, we only did the drills in the community setting, and then we provided tools and coaching if they wanted to engage their EMS, if they wanted to engage their hospitals that they work with. And some of them did, but many of them just kind of simulated, like up to the point of when they call care, and then they made sure everybody knows, you know, what's the number you call? How do you give report? Those kinds of things that can still be done. And so as we've evolved the program, we have brought the hospitals and EMS more formally in. And so the most recent iteration of this, we had birth centers and hospitals enroll in the program together and work together to engage EMS. Often the hospital has better access to EMS in terms of getting them on board for different training initiatives and stuff. And it's a lot of coordination. So we still hold out as the gold standard that the interdisciplinary drill, that the drill in fact moves over the course of the simulated emergency. And also our tools support still doing just the half of the emergency that happens in the community setting, or even just the half that happens after arrival at the hospital, so that a hospital doesn't have to coordinate, you know, a bunch of midwives and EMS providers. They can just say like, look, here's a drill. We pull, you know, you can answer a couple of questions on our site, and you can pull down a drill that is just, you know, a patient is arriving now, accompanied by a midwife and has lost 1,000 cc's of blood so far. And now we're going to pick up the emergency. And that's different. That people need to do different things. Different orders need to be put into systems and so on, versus, you know, in that scenario versus someone who gave birth at the hospital that they're already at and goes on to experience a hemorrhage. So there's a lot to learn. And I would say it's been a little bit of like just trying to get the hospitals to realize that they're not just at the end of a, you know, a train wreck that's coming in. They have actually a really important role to play in planning and practicing and making sure their systems are ready to go as well.
Wow, that's really very, very useful information. And as I think about that, really, what is being described from the other solution as well, in terms of, you know, attention to cardiovascular conditions and spikes and blood pressure, is something where we've equally had, you know, challenges. I recall very early on, maybe I guess it was about 4 or 5 years ago. Now I'm losing count of time. Everything is like pre-COVID or post-COVID. I think it was just pre-COVID, where I had spoken with a very influential group and said, hey, why don't we have, you know, mothers using blood pressure monitors, right? Like just making that kind of simple change, and encouraging, you know, people have thermometers in their homes. Pretty much everybody has a thermometer, right? But how many people have blood pressure monitors? Well, they don't. But and yet, in fact, they're just as valuable and as important. And that, you know, that was kind of the response. That was, well, you know, there's not a protocol for that yet, right? So a standard of practice hasn't been set for telling women to monitor their blood pressure. And now, even as we have seen from what is being described from the technology with CT cardio and the Circle Health, that itself may not even be enough, that they're even better detectors of these signs and symptoms prior to it showing up as symptoms, blood pressure related indicators. So I'd love to maybe flip the script a little bit and equally invite Dr. Barron and Neil to tell us a little bit about your journey equally. I think Amy has described a lot of coordination that's had to happen and prioritizing changes to just put in place, you know, some basics from the standpoint of providing care and coordination of transportation and response. How about on the preventative side? Sometimes I think that can be an even more challenging space when we talk about preventative health and the role that a patient themselves can take, right, and the participation of their own health preventions. Please do share with us, what has that journey been like getting started and raising attention around this tremendous opportunity?
Needless to say, it's very, very difficult, right? And we have so many barriers within our healthcare system. I mean, nobody really wants to talk with you unless they're going to get paid for it. And this is really the big problem. Instead of being concerned with being preventive, it's how much are we going to get paid by the government to have this device. I'd like Ehud actually to talk a little bit more about our technology, because our technology is groundbreaking. Most important, we're talking here about maternal health, but it's, what we're doing is we're opening up the world of nocturnal medicine, really. and really learning about people during the night. And the bottom line is that everything pretty much occurs during the night. Unfortunately, most of us die during the night. So this is new data that has never been available before. And Ehud, you want to go a little bit further in talking about what we're going to see and what we're doing and how it's done?
Yeah, definitely. By the way, I want to apologize that I was short because Neil warned me many times, say, be careful, don't speak more than 5 minutes or something like this, because he knows that I speak. He cannot stop me. So
This
I
is
say,
a
okay,
this is
I'll
a
do it
former
very
professor
short.
at Stanford and Berkeley, so he's a teacher.
Well, I also, while we're going into this, let me kind of set the stage a little bit, because there was something, Dr. Byrne, that you mentioned in the beginning as you began to speak, and that was apologizing for being a cardiologist in the maternal health space. And yet we know so fundamentally, when we talk about creating interdisciplinary teams, I can't think of one that could be any better than, kind of the three wheels, right? Of course, obstetrics, but along with endocrinologists and cardiologists together are so key and imperative in terms of ensuring health and wellness as we kind of look at the landscape of, morbidity prevalence, right? The prevalence is amongst cardiovascular disease alongside with diabetes. So, yes, please do tell us more about this technology. I saw this kind of solutions beginning to hit wave, maybe I want to say 10 years ago. At CES, the Consumer Electronics Show. It's the first time I started to see that. Everything from, a pillow that as you're laying and the pillow is detecting information, to all these other gadgets, and you've created one that's very eloquent. So we'd love to all learn a little bit more there.
Yeah, so there are many, many gadgets, and this is one of them. This is not a gadget, actually. This is an FDA approved device that can show you the blood pressure, and we are working only with FDA approved device, so it's not the typical Chinese $10 watch. It's something that doctors can trust and can base their diagnosis and treatment on this. And just to tell a little bit about the background, since I graduated from medical school, I was very interested in what happens during night with the cardiovascular system. Because we know during the day, sometimes we measure, but during night, we don't know. And many of the things that happen to us, for example, most of the heart attack happen at night when people are sleeping. And this was always like a mystery to me, why a person that's sleeping at home will suddenly get a heart attack and so on. So I started to measure this thing, and I discovered that the night that looks like a very quiet time is actually not quiet at all. There is very stormy changes in blood pressure and so on during the night. And then I started to look into this more. And then I talked with friends, doctors, and they say, we want to draw your attention to preeclampsia. Because in preeclampsia, we know that this process that normally takes many years until hypertension develops, the pregnancy accelerates this. So because suddenly you have a very big burden on the cardiovascular system, and problems that normally would take many years happen in weeks. And again, the main problem is to detect it in an early stage, like every disease. If you detect it in early stage, you can fix it. If you're too late, there is very little you can do. By the way, people are not aware of this, that hypertension, which is like the major disease today. About 1 in 4 people have hypertension, and most of that hypertension, even when they are treated, the doctors don't succeed to, only 20% we succeed in treating them, and 80% not, which is amazing because this is the major reason for a major cause of death, mortality from, it's number 1 in all the world. So then I thought, this is something that I don't need to wait many years. I can, in few weeks, see how it develops. And every week is very, very important. In cardiology, you say when you need to rush people to the hospital if they get heart attack. So you can say that time is muscle, is the muscle of the heart. Every minute that you miss, you lose the muscle in your heart. In this case, I would say time is baby. Like every minute that we miss, there is a damage to the fetus and to the mother, of course. And you know that sometimes the damage is even postpartum, that it happens after. And there is also, like with COVID, there is long-term problems. Like I mentioned, that mothers that experience preeclampsia are much higher risk to die from heart disease. So all this is very, very good reasons why to catch it in early stage. And instead of doing this big blood pressure with the cuff that people always forget to do, the only thing that you need is a ring. So many of the pregnant women wear a ring anyway, so they just need to wear the right ring. And then you can start to get immediately the indication if something is going wrong, and of course, draw the attention of the doctor to this. Once you detect it, it's very easy to control it, because both beta blockers and calcium channel blockers will work like a charm. They will solve the problems, but you need to detect it in early stage. So this is the story behind.
Thank you for
It looks
that,
like
Dr. Baron. Yep, go ahead, Kelsey.
I was just going to say, it looks like we have a question from William. William, your sound is off.
Okay, how about that? Does that sound good?
Yes.
All right, great. Thank you very much, and thank you, Dr. Baron. I really appreciate your comments so far. It sounds like it's a really exciting potential with your product. My question is about, I believe AI is part of your product, and tell me, confirm or not, but it sounds like that's possibly part of the product. With all the concern about how AI is sort of hype, and then there's fear about this, how do you see AI as being an effective tool to improve maternal health, and how does it specifically address it in your product?
Ehud, did you hear them?
It was a question to me.
Yes.
Yes.
That's okay.
William, perhaps rephrase the question for him just for a moment, if you don't mind. Please pose the question.
The question is, I'm assuming that there's AI is part of, essentially working on the cardiovascular data that you're collecting. So I guess I'm interested in how that works with your product, and sort of how do you see the concern that people have right now in AI, both the hype side and the fear side, and sort of the overall, how do you see AI in general is a tool, how effective do you think it's going to be for improving maternal health overall?
Oh, okay. I like this question because when I was at Stanford, actually, I was working on the first wave of AI. It was many years ago in the 70s, like 45 years ago. I started to work with what started to be called AI. And I believe that the name is wrong because there is nothing intelligent in this. It's just an algorithm. It's algorithm that is a little more sophisticated, needs more computing, but there is nothing mysterious in this. It's basically a statistical tool. And what we do, the problem is that the result of our what we do looks something like this, which is
We can see it.
like a graph with thousands of points in it. And if you think about this, people say, oh, you show it to the doctor and the doctor will know what to do. And I'm very sorry to tell you the doctor doesn't know what to do because they never saw continuous blood pressure. The other thing is I say to people to go over this will take hours for the doctor to look at this. And who is the doctor that is going to look at this all the time? They are not, doctors are very busy people. So the AI is an essential part because someone needs to go through these graphs and interpret them and summarize it for the doctor, saying, hey, what you see here is an increase in the systolic blood pressure, but not in the diastolic, which means that the problem is this and this. And at the same time, we look also on the oxygen, because some people, the problem is because of sleep apnea. When they are sleeping, they stop breathing. It also creates some fluctuation in blood pressure. There are some movements that also create this fluctuation and so on. So it means that a computer, and this is AI, and this is what AI is doing much better than a human doctor, because taking like thousands and millions of data points and put them together and make a very simple conclusion from this. So this is exactly what we are doing. So what we are doing is taking many cases of people in different stages of, for example, of hypertension, or different stages of, now we are trying to do it also with cancer patients and with other patients. And we want to see what happens over the time, how things are evolving. And basically, I am not big fan, or I don't believe so much in correlations, because most of the medicine today is based on correlation. You make a correlation between drinking coffee and cancer or something like this. But this doesn't mean anything. For example, if I bring this example with the coffee, in the beginning, people say coffee makes generate cancer. But then it turned out that it's not the coffee. People that drink coffee also smoke. And the smoking is the one that makes the cancer. So correlation is not, what you need is you need to find the cause. And if you follow something point by point, then you can see every time that this happens, also this happens. This happens, and then you start to understand that these two things are related. And of course, you need to go to the physiology. AI in itself is meaningless unless you understand the underlying physiology. And this is why I mentioned this, that I went to see exactly what part of the body is the one that creates this hypertension, this preeclampsia. And then you can follow this and go into the blood vessels and study or even on the cell level and see that the cellular, the endothelial cells, they are reacting to changes in blood pressure, and they are the one that create, that atherosclerosis, the main problem of heart disease, is created by these endothelial cells. And the endothelial cells, by the way, are not bad. They are just trying to repair some injury in the wall of and they patch it with cholesterol. So this whole thing, so the AI gives you only the immediate processing. You don't need 1,000 doctors, you need one good computer that will do this for you.
So Dr. Barron, thank you for giving us that outline and description. I think that's really very helpful. And I know there was a question in the chat that was asking about doing comparison with control groups of pregnant and non-pregnant. And I presume that you are engaged in studies or in the process of developing studies that look at that. So I want to turn our attention, because folks might think that we have two separate presentations and approaches to addressing maternal mortality and morbidity that are disparate, right? That they're completely different, that there's like this chasm between the two. But in reality, they actually go hand in hand with one another. And I want to pause and give us a moment to reflect upon this. Amy, early on, you had made a remark around what we have also, well, those of us in the space have on the front lines have seen, where providers, once they've known that a mother has made the choice to deliver in home, as an example, and then presents in a facility needing assistance, that there's sort of this jarring reaction that occurs, and this maybe even some judgments made about how to proceed with supporting this particular the patient or that particular case. Wondering, when we think about technology such as continuous monitoring as is being proposed, and performing this remote monitoring as part of the course or regimen of supporting a pregnant individual, might there then be this opportunity to sort of create a remote sort of monitoring of mothers who make the choice, or parents who make the choice to deliver in their homes, such that facilities might have access to the type of data that Dr. Barron has described, so that their cases are familiar and it be kind of preemptive measures? What are your thoughts on that?
I do think there's a marrying of these technologies to, get data or get patient, input or community-based clinician inputs to the hospital. I would argue that there's not a role for continuous fetal monitoring in out-of-hospital births, because I would argue that there's really not a role for that in hospital births for low-risk patients either. That it's not been evidence-based the whole time we've used it. And so the interventions that involve increasing the use of it are likely to increase, a lot of the interventions and complications. And so I think that I have actually a very cautious approach to adding monitoring, especially repeated monitoring, because of the just mathematical thing that happens when you continue to screen for something. You increase the likelihood of finding a false positive. And so we see actually pretty frequently, one of the most common reasons that someone risks out of a planned out-of-hospital birth is for developing hypertension. And of course, a lot of those are real cases of hypertension. But you also, the question about whether the device itself or the algorithms behind it have been validated on pregnant individuals is a really important one, because just regular blood pressure cuffs often have never been tested on pregnant people. And there's all kinds of differences in how vasculature, grows and changes in pregnancy that we don't know for sure that the same kinds of findings that we find in one device mean the same thing when that device is applied to pregnant people. So I think there's just a lot of questions about how to appropriately apply these. I think there's patients who can benefit from obviously these kinds of screenings, especially if they're far from care. But I wouldn't I think, the use of them, I think, is more for identifying patients that really do need to be closer and are not safe in a maternity desert. There are people that can take the risk of living 45 to 90 minutes away from a facility and just get there in time. But if you're out there with severe risk factors for hypertension or preterm birth or whatever, and if there's a way that we can identify those, then we do see models in some places, and I don't think they're optimal, but they're safe, I think, where patients, move and physically just stay, whether it's with a family member or some other kind of place to be until the baby is born. And so I think it really needs to be done carefully. And but I think I'm pretty excited about the layering on of certain kinds of particularly teleconsultation kinds of things where there's so much, you don't have to physically move a patient to a hospital in order to, get a closer look at the baby. So things like point of care ultrasound, I think, is an interesting layer on, and those kinds of things. But yeah, I'm also curious to hear the other presenters' take on how they imagine this being used for kind of low risk patients in who might be affected by maternity deserts.
I would like to.
Before you jump right in, Dr. Barron, just want to be cognizant of the time. For those who need to leave, and I know some may need to depart, we want to thank you so much for joining us today at our Innovation Showcase. We are going to continue with a brief remark from Dr. Barron in response to Amy's question regarding the benefit for low-risk pregnancies, utilization of continuous monitoring technologies, and specifically the one that's being presented to us today. Dr. Barron?
Oh, okay. I think that Amy response is very typical, and doctors are very conservative. When I started to work many years ago on CT and MRI, I showed this doctor say we don't need it because from X-ray we can do it, and it will confuse people and so on. We don't need it. When they started with pulse oximeters, people say also, you don't need to give people pulse oximeter. If they have a problem, they should go to the hospital and do a blood check and so on. So in the beginning, it's always some resistance. And I believe that this information, by the way, doesn't need to go to the patient. It goes, and this is the AI. The AI is monitoring you. There is what is called AI agent. It's something that monitors you, and they tell you what to do. So the only thing that the patient needs to do is wear the ring. Doesn't need even to know what happened. And someone is monitoring you. And people that monitor themselves live longer. This is a fact. So I think very differently about the future.
Mm-hmm. Well, we can certainly say that it's okay to think differently, and that's where new discoveries abound, is out of diversity in our thoughts and our experience, and our research too is what's needed, right? More research. I don't even hear Amy saying no. I think Amy is saying we need more research. It's one of the reasons why validated devices for pregnancy. I think about AMC is a great example of that. The AMD validated device, and there are other major manufacturers who'll say to me, Fran, I can't, you know, no, I want to be cautious in what we say because our device isn't validated for pregnancy. So they themselves are saying that. But what I'm hearing most of all, out of everything, even in the difference of opinions in physician, is that probably it's not disputed that more research and more funding towards research in this space is needed. And that perhaps we could maybe all share that as being part of our agenda for next year. And David, I'm going to put you on point for this one to help us out of it, is that we do put forth some language and some encouragement around policies and funding that will lean in on more research and discovery in this space, because there is so much that is just, quite frankly, unknown and to be discovered. With that, I want to thank everyone. Any last closing remarks from yourself, David, or from any of our steering committee members?
No, I thought today's discussion was great. I'm very excited for November and for heading into 2025. I appreciate everyone joining us.
Thank you, everybody, for your time today. Our next month, November, we will continue the Innovation Showcase. We have, help me remember, Kelsey, we have Philips and any names come, I'm escaping. Well, I know Philips is going to be here, and it sounds like that we'll have Fetal Life here next month too.
We'll have Fetal Life as well. And I just took a peek at that this morning. We do have 3 other individuals who have signed up. So that's exciting.
Oh, that's very exciting. So it's going to be a full house next month. All right, everyone. If you'd like to hear the replay of this, of course, it's available on YouTube Live. And thank you, everyone, for your time today. Make it a great rest of the week.
Thanks, everyone.
Bye.
Thanks, everyone.
Okay.